Good afternoon, everyone. Welcome to the Grand Rounds, Med Education Grand Rounds this afternoon on a Thursday. We will be talking about social determinants of health, especially after the huge impact of the COVID that has had on us, our communities, and our practice. And this seems to be a very good refresher and an introduction to social determinants of health. We have with us Dr. Kate Nolt. She's an PhD, Assistant Professor of Public Health and Healthcare Management, Department of Clinical Research and Public Health, who has had over 20 years of experience and a lot of work in public health and health promotion. And she mainly focuses on health and healthcare management. She's done many projects, different countries, Dominican Republic, Haiti. Her experience is conducting community health needs. And she has to be, we're very honored to have her with us today and be a part of this Grand Rounds. We're also honored to have John Stone. If you've all gotten the invite, you do have the pre-read, which is a great article from Dr. Stone, and we're going to be a part of listening. Hopefully he's a part of this discussion going forward too. Talking a little bit more about Dr. Nolt, she has specific training and education in health disparities, health services research. She's done a whole bunch of competitive effectiveness research and patient-centered outcomes. She's seen and continues to oversee hundreds of programs, both graduate and undergraduate research, which is health-related topics, including primary, secondary, and tertiary healthcare issues. Dr. Nolt's research focus is in the subject matter of addiction prevention and intervention, and she specifically helps in is involved in reducing risk behaviors that can lead to substance and behavioral addictions. One of the things that I was reading through her resume, what caught my attention is she does currently pursue research interest in internet gaming disorder among the youth, and which is now a new and a huge area of growing research. She does teach higher education and administrative positions at the graduate and the undergraduate level. She continues to be an elected leader at Alcohol, Tobacco, and Drug section of the American Public Health Association. She co-chairs the Policy and Advocacy Committee for ATOD section. And as you can already guess, she's authored for many things, and she has to be 4 policies for APH-related ATOD issues, such as e-cigarettes, cannabis, opioids, and tobacco industry. Dr. Nolt, thank you so much for being gracious enough to be a part of this Grand Rounds and delivering the Grand Rounds. And the stage is all yours.
Well, thank you very much. I appreciate being here. It's an honor to be presenting on this public health topic. I want to say that the conversation, this is hopefully going to be a pretty active and engaged conversation. The topic is, of course, a hybrid approach to working in healthcare delivery to include social determinants of health. Some of this and the hybrid is between the partnership between medicine and public health in terms of fields and how we deliver care to patients and communities. So one of the things that, my thing's not working here. Okay, so the disclaimer, this is important. We are not going to, nor should we try to solve any problems today. This is meant to provide information for you to consider and reflect upon as you move through your into your practice of medicine for whatever specialty it is, or if you're in community health, it's for your consideration and reflection, whether you're working with individuals for treat and cure or you're working with populations. And I want to encourage open and judgment-free discussion. So let's start with the practice of medicine. So I'm going to put some questions to you, and they're really not hypothetical questions or rhetorical questions. I really would love to have some participation here. And the first question is, why does medical practice exist in the first place? So why do we even need to go to, you name your specialty? You can unmute yourself or raise your hand. I can't see everyone because of the screen sharing, but if anybody has a hand up, I'm not going to be able to see it. Or you can use the chat, because I assume someone's monitoring the chat here. right? So let's assume then, if no one's going to volunteer their answer, that we understand that medical intervention is needed. It could be surgical, it could be, medications are needed. So we need the practice of medicine to help heal. So many populations don't have access equally to others. So access to the resources is scarce for a lot of populations and individuals. Okay, so when we talk about medicine, we can talk about individual treat and cure. So diseases are treated initially, and sometimes it's the only medicine or medical intervention that people have. So they come to a physician because they are experiencing symptoms to some degree. They're experiencing symptoms of illness and they need to be relieved of their symptoms, or maybe they go to the ER because it's acute. So that may be, once they feel better, they go home. And that may be the only intervention that they get until symptoms get worse again. They may have to overcome a lot of barriers just to get that treatment alone. But most often, people who are economically advantaged have easier and more access to medical care than folks who don't. So the question is, part of the question is to consider as you move into the practice of medicine even more, get deeper into what you're going to be doing. Is medical care in some cases even legally offered? So that comes from some discussion about if you go to another country, let's say we're talking about global health. If you go to another country and you're licensed in one country to do practice, are you truly licensed, and should there be some question about the legality of you practicing in another country, even if it's part of a mission, right? Is it ethical or culturally relevant what you're doing as a physician or in your group, especially when serving diverse populations? If your practice comes from a one-size-fits-all treat and cure for whatever illness you're treating and curing, and doesn't consider cultural relevance in the way that it's delivered to the patient, and then the patient leaves your care and there's no way to have built-in follow-up, is that ethical and is it culturally relevant practice? And I think some of these questions come up a bit in Dr. Stone's article, which I'm really hoping all of you who got it, read it, because it's, again, part of the reflection part of how you practice medicine and where you find your own level of social responsibility in that practice. So before we talk about public health, there is a video that I'm going to attempt to do from this link. Let's hope it works. So you'll have to tell me if it's not coming up. Let's see. Let's see if it works. Nope, that's not the one. Okay, so we're going to go with the fact that I brought it up. So tell me if you can see the video on your screen. Let's see, I'll try to do a new share. So most of you may know what public health is and may have experienced it in some level in your journey to where you are now. But I'm going to share this particular video to sort of pay attention. It's fast, so pay attention if you could to some of the things that are in this video. Let's see. Can you guys hear it?
Public health. What do I think it means?
Yes.
Yes.
Well, I think that's private health. You mean?
Hygiene.
I don't know.
I'm really excited about this sticker campaign. Everybody can see that we're actually doing things everywhere. So when people walk by, they feel like, oh, this is public health. Everything around you is public health. The stickers will be like our voices constantly reminding people that this is public health. This is public health. This is public health. By seeing these stickers, they'll see that we do a lot, and they'll see that they actually need public health to keep them healthy and to keep them well. Buses in New York provide cleaner air for everybody. Thank you. If there's a bike rack, that means that more people are actually going to be riding their bikes instead of taking cars or taxis. Let's definitely sticker that. Having a fresh fruit stand like this encourages people to include fruits and vegetables as a part of their daily diet. We're sticking it so people can see that this huge cigarette isn't good for them. The message is clear. Water safety is a public health issue because if we don't protect our drinking water, then it can trickle down into the food that we serve. It really helps people to pay a lot more attention to their nutrition and to the things they're putting in their body. It's public health right there. Community health bans are a public health intervention at a community level, making sure that the aging population not only has access to certain services, but has transportation to get there.
My definition of public health relates to the environment.
Public safety.
Eating well.
Free clinics.
Sewers.
Washing your hands.
It's teaching safe sex.
For AIDS awareness.
No smoking the kinds of publication, yes.
Maybe air quality. Truth in labeling.
I think it has to do with your eating habits.
Educating the public about ways to improve their health and happiness.
Helping people with cancer.
Being on constant monitor of your own body.
Taking care of the citizens of our city.
Public health is about controlling the factors that you can't control that control your health. You're only as healthy as the world around you. Public health is your health.
Okay, so now the question is, if you guys want to put it in the chat, or what is public health to you, and how, what things did you see that are part of public health? And I don't know if you're, Angie, are you looking at the chat, or is Ashwini, are you? Okay.
Prevention. Somebody says prevention.
Safety, prevention, yes, thank you. What else?
Patient care.
Patient care, yes. But did anyone see anything that could be a barrier to people getting to you or having access to you as physicians?
Somebody said transportation.
Yeah, so I pulled out the ones that certainly we encounter a lot. Thank you. Economic means, absolutely. Transportation for sure, right? So access to healthcare alone, it can be a barrier for many. We've talked a little bit about that already. So in public health, there was actually a tool that I happen to love to help overcome some of the transportation issue. Did anybody pick it up in the video? There is ways to overcome the transportation issue. If patients can't get to us or to our clinic, what do we need to do? Or try to do anyway? No takers? How about if we go to them? There was a mobile unit in there, right? Anybody catch the mobile unit?
Well, I just did.
You just did. Yeah. Okay. That made it in. So mobile units, right? So mobile units can be used. They're expensive, but they can be used to bring you to them, right? To the communities that can't get to you. So eating healthy was part of that. Housing is also part of issues that can prevent people from being able to access care. And we said generally in the video, the environment was discussed. So the social determinants of health include, thank you, that's a wonderful comment. Yourself, you're the first line defense for public health, your belief, your actions, your communicating, your participation, absolutely. So where we live, work, and play is essentially our environment, right? It's everything that we do that can affect our health. So if you look at some of these pictures, This is a picture of a city that's got you. What do you see? You see highways with cars moving around. And what else do you see? Like in this picture, this was Detroit, I think, in this picture. And here's a nice neighborhood with the vans and clean grass, and the environment looks pretty good here. So if we work or live in these areas, it's probably pretty decent. I think there's some swimming pools in this one. How about where we eat? Our kitchens, what we have access to. This top picture is a picture of a food bank that serves a community. And you can see there's a lot of high-end appliances in here and a lot of food lined up. This is actually one family's home, and the kids, if you can, I don't know if you can see very well, the pictures might be small for you, but there's not a whole lot of appliances in there, and the kids are sitting in different spots. They look a little crowded. Look at the playground differences. So you have a beautiful playground here. Believe it or not, this alleyway is also a playground for these kids, where we live, work, and play. What if where we live, work, and play looks like this? This is also a community. So in this community here, there's only one area for running water. There's like 800 and something people that live there. The homes, I don't know if you can tell, the homes are like shanty homes. This is a kitchen. This is another home where there's no paved roads, rural. This is a rural community. There's trash nearby, so of course methane, as the trash decomposes, you have methane gas that comes up in the air, and in the breezes, it goes over into the community. And this little lady was extremely malnourished and living in this community, this rural community. And in this picture, she's almost 2, and weighed just a few pounds. She was clearly malnourished. And I was part of a group of a couple of people who helped to relocate her with her family into a place that could get care for her. And she was found to have HIV, and she ended up getting treatment. But what was around her, where she was living and where her family was working and where she was playing, clearly played a role. And what she had access to clearly played a role in some of her outcomes. So the CDC defines social determinants of health officially as where we live, work, and play that affects a wide range of health and quality of life risks and outcomes. So we've already talked a little bit about some possible what's SDOH, social determinants of health, are. But if you could, does anyone know what they really officially are? You can toss out a couple. I'll start off. Education's one of them. Yes, income. Absolutely. How about housing? Housing's one of them. So all of these things can affect our health status and our quality of life. So when access to healthcare, safe neighborhoods, yep, or not, yes. Social supports, yes. So all of these things, when a patient comes to see you, all of these things are playing a role in the health status of what they've got, not just what their symptoms are. So how can medicine and public health use these to partner to better improve quality of life for everyone, and thereby, equity? We're talking about health equity, right? So if we do nothing, that's not going to help, right? So we need to mobilize people in our communities. So imagine you in practice, whether it's at a hospital or in a private clinic or public clinic, there's a whole community around you of possible partners that you can mobilize to use as resources for your patients within your practice. So understanding the constraints that your patients have or believe that they have, and figuring out ways to serve them a little bit more is part of this partnership between public health and medicine. And neither needs to work in a silo to help improve, to practice. So for instance, teaching some skills that'll last long after a patient is done seeing you might be part of what you do. So what does that mean? So if you learn something about your patient that helps you be able to say to them, it sounds like you may have food insecurity. Maybe we can help you access food and it's healthy. It's one thing to have a SNAP card, if you know what SNAP is, or have access to WIC. WIC is the Women, Infants, Children program that for children 5 years and younger and mothers to be able to feed their kids healthy. It's a public health program that most, I believe, health departments facilitate in communities. So, but some doctors may not know about that. But knowing about that and having a patient, whatever your specialty, having a patient that could benefit from that because you had maybe a few extra minute conversation with your patient, and being able to connect that patient to those resources can make a huge difference in their health outcomes moving forward. But that's an ongoing commitment for your practice, to build that kind of relationship, to mobilize your health departments and the nonprofits that may be able to provide additional resources from who's around you, and keeping it going. So these are possible interventions that you could use in your practice of medicine as you start to explore how or if some social determinants of health are contributing to the health status of your patients. So a way that an intervention could work is there is a model currently that's actually very old, but for some reason it kind of went off the radar and now it's sort of coming back. It's community-oriented primary care. Before I get into this, I want to just go back to the pre-read, and Dr. Stone, if you want to sort of hop in here and talk about how a physician may feel about their responsibility to do what I'm suggesting in this presentation. Dr. Stone, do you want to comment on that at all, or? Sorry, I hope I'm not putting you on the spot. I think we sort of understood you might say something.
Hey, everybody. Appreciate being part of this and what Dr. Nolt is doing. I'm inclined to think that many people would sort of feel lost. That, well, this is so far outside of my ordinary preparation, although I care about these issues and so forth, but how do I get started? What do I do? How do I learn what to do? So, and that can be pretty paralyzing. So I think a crucial question is, that how do you move forward once you say, yeah, there's all these needs, but what should I do and how do I do it?
Thank you. So that you would think I would have paid you for the next part of my thing, but I didn't. That sort of was a good transition and you didn't even know what was coming. So it's a great question. So, oh my gosh, I've got housing, they're having food insecurity, they're having all of these. So it's okay for you as part of a partnership in your practice to say, listen, we can't take all this on, it's way too big, but maybe we can take on food insecurity because we know we've got a great county level approach to food insecurity, and that's something we can take on. Maybe we can just have the resources with WIC at our local health department, through our local health department, to say, hey, look, we want to know you guys well enough and what resources you offer, so that if we are talking to our patients about these things, we'd like to be able, at least to be able to say, hey, here's the number to the health department, they've got this great program, and maybe you can connect with them. And then you can also note it, and later on, if you on a follow-up visit, you could say, hey, were you able to connect? Was that helpful? And then you can also decide, to work with social workers and psychologists and just sort of keep this referral handy, these referral handy networks handy for your patients. So it's not, which I think goes back to the slide that I had earlier, which was, if we do nothing, how does that help improve? If you're in the practice of medicine to help improve the health status of your patients, this is one way that you can, among many, that you can take on more to contribute to how you as a physician can help your patients address some of the issues that could be contributing to why they're not getting well. So this is a marriage between medicine and public health. It's a model. And it really takes a village to engage the community. You want to engage, or at least get to know some community leaders, whether it's through a faith-based organization or some other type of organization, that the leaders of the community, maybe there's a community health worker, maybe the local health department has a community health worker force that they've distributed, that are working with. Definitely find that out, connect. And so you want to define what your community of interest is. So you want to say, our community of interest, or outside of the medical practice that we're doing, has to do with those who are food. And I'm saying food insecure because that happens to be a passionate topic of mine, and I do a lot of work in that area. So food insecurity, then we want to work with people, not just the patients that come in, but we want to be sure the kids are with WIC, or the kids are with that there's a food pantry they're connected with. I had one situation where someone came to me and said, we found out that our local Panera Bread chain was throwing out all this food that was still good. Wasn't moldy, it wasn't whatever, but because of their own practice. So the food pantry and Panera Bread connected, and they ended up getting a lot of food from the Panera Bread because they were just dumping it in the dumpster. So that's an example of how a partnership can work. So you want to identify the health problems that are the priority health problems if you can. Again, the data from a local health department may help you do that. They may already know what the priority issues are in your particular community. If you're working in a community or within, there may be an epidemiology department or something in your hospital, or an epidemiologist they work with that can help you understand that. Developing and implementing some interventions we've already talked about, and then evaluating and figuring out whether or not what you're doing is helping at all. So the basic principles, we won't go into this too much, are to focus on all patients within your community of interest, not just the ones that come in and visit you, but sort of, if you do have community health workers, a good thing to know, utilize them to help you understand who you're serving as a physician. And do care based upon the identified health needs at a population level if you can. Don't forget, this doesn't all happen in the exam room. This can happen if you're in a practice. This can happen at the front desk as part of your intake coordination. Like maybe there's a little bit of a survey to ask if, for someone to fill out, or for someone at the front desk to say, hey, can I just ask you a few questions about some of these things? And again, as part of a practice, you guys can make this a practice decision. And then be transparent in the process with a team of people that you're working with, because this is an interprofessional approach to the practice of medicine and includes public health. So all stages of the health illness continuum should be covered when you are considering some type of intervention. And again, the community participating for itself, finding its own agency that way through you and your practice, if it works that way, is very powerful. So who's on the team? Well, this is an interdisciplinary kind of recruitment thing. Know who is engaged with the community and who's missing, and celebrate the diversity of that, and understand the root cause of the disease and what the needs are, so that some of these social determinants of health, that shouldn't have happened, can get addressed, and be open to perhaps having some training regarding biases and understanding the lived experience of the people that come to you from the community. So even if your practice is not in a particular community, but it's more, let's say you're at a hospital in an urban hospital setting, and people are coming from all over the county, the rural, whatever, and they're your patient, they're your specialty. I don't believe that that negates you understanding what's happening in their lives in order to give them kind of a more holistic, humanistic, comprehensive approach to how you're caring for them. These truly powerful interventions should really be understood by everybody, regardless of whatever the level of education is for the people that are engaged. Even non-medical people can serve as sounding boards. So those would be, I think we talked earlier, lawyers in the community, scientists, or anybody, psychologists, can community and lay people can help identify, what's happening in the real world of your patients. And so this is a community-oriented primary care approach. And, evaluation, some people kind of cringe at this, but if there is a way to get feedback, nowadays you always get an email from a practice you might have gone to, we'd love to know how we did, kind of thing. But what's interesting about that is even with practices that have socioeconomically disadvantaged people as their patient group, there is such a thing as a digital divide. A lot of these communities do not have the ability to access to provide feedback on the experience they may have had with you. They may only have mobile phones, and maybe the survey itself is not friendly to mobile phones. And so the people you're hearing from may be only people who have access to the internet and a computer or a way to be able to answer the survey. So you may not be getting the feedback from the very people who really need you need to hear from. But it doesn't have to be a complicated process, and the lay people and community members and professionals help to plan how that feedback's going to be received. And then, it could be, you could do a baseline to post intervention, like what's different between when they first came in, how are they doing? And then 3 months later, if you want to follow up with them and get some type of post intervention feedback, you could do that as well. Ideally, if you're getting information back, some people call it patient satisfaction, client satisfaction, whatever they want to call it. Ideally, these would be evolving, and these surveys or the evaluations would happen predominantly from beginning and concurrently while the intervention's ongoing. How are things going? It allows the team of people that are the interdisciplinary team to know what's working and how to track things and how much time and resources to allocate. Now, can this happen, or should it happen with you? Maybe not. But if you have let's say a health department that you're working with and you've got a partnership with them, they may be able to help you facilitate some of this. Perhaps a social worker that you're working with, or a family services agency close to you that you're working with may be able to partner in all of this to capture some of this information. And some social worker may say, look, we love working with your practice. I want you to know your patients are really doing well. Or this is great, but it seems to need a little bit of tweaking here or there. That's it. I just we do if we do have a case study that I'm gonna share with you in a moment to get some feedback. Any thoughts, questions, chat? Angie, I don't know, or Ashwini, I don't know. Thoughts?
I have a few questions. I guess as we go through the chats, I've been getting a few text messages to Angie here, put across a very nice message. Like, if we were to talk about our community, if you were to talk about the problems that we have in our community, one of the things that could have happened is if this physician, whoever in the community, was talking to this young kid who's 18 having some problems and listened to or heard about or explored more, would this Texas even happen?
I'm sorry, I missed the last part of the question.
The shooting at Texas, like,
yes,
that's community health, right? That's community involvement. That's people knowing to try to get to figure out what's happening in the group of people that you take care of.
I think if the question is, would something like the Texas shooting, which is horrific, and it have happened, had there been some type of intervention sooner with the 18-year-old? Is that the question?
Correct, yes.
Yeah. So could it be possible that a physician maybe would have known and didn't do something? Is that the question?
Yes.
Okay, yeah. So I think we could probably all agree, and if you don't, that's completely fine, that any intervention with this young man to have on the level of a physician, a teacher, a counselor, a guidance counselor, a neighbor would probably have helped, right? So this is a mental health issue. If you work with a social worker in your practice and this young man had come to you and you were a little bit uneasy about what happened, there are hotlines that you can use and know of. And again, I'll refer you to the local health department that probably sees some of these, and there's some national hotlines, and there's NAMI, the mental health, the National Mental Health Institute that has these hotlines. Like, these are resources that should be available in your practice, so that if you have a concern, then you could be saying something that could potentially, it's no guarantee, right? There's no guarantee that anything you do would protect this young person from doing what they do. But again, it comes down to this conversation of, doing nothing, doesn't help. So I'm not sure if I answered that question, but if a physician puts a note in a patient note, right? So who sees that patient note? The minute that patient walks out of your office, even with a patient note, if there's not an intervention or some additional questioning, there is a risk that, that person's going to go do what they were planning on doing all along. The question is, do you feel empowered enough as a physician to follow your instincts to say, I think I need some additional something in here before I let this young man go? And so you might be able to, and I'll take any comments or conversation from anyone in the group who may want to dovetail on what I'm saying or disagree or whatever, but this is why partnering with people through public health and through all these different departments can give you the resources to provide help. People can always say, no, I don't want the help. And of course, what are you going to do? You can't force them. But what barriers are there for physicians to say something? I'm not quite sure. Are you talking about legally? Whoever asked that question.
I guess it just means to say in general, like why would we, like, we know something's going on. Why don't we document? Why don't we make it very clear? But to answer Angie's question, it's again, what's the take-home point of this lecture? What's the take-home point of this grand rounds? It's responsibility, right? We as physicians have to take the responsibility to understand what happens in the community. This is not just going to be a service that you cater to and everything falls into place. There are different people, different groups, and we should be able to cater to the group needs of all the community. And as you can see, the take-home to me, Kate, you can help me understand also, is the fact that this is a responsibility on the part of physicians to understand and integrate the different social determinants of health. So in general, there are no constraints, but do we do it is a question mark. Do we follow through is a question mark. And it's just not follow through, right? Is this my responsibility? Should I take care of it? Or how do I involve somebody else to intervene to prevent this from happening? Is something that we have to start thinking in the larger scale.
I think you did a great job of that one. Dr. Stone, did you want to follow up on that somehow? Thank you, Ashwini.
Yes, I did, and thank you. I mean, part of the issue, as I think about it, and I tried to write a bit about it in the article, was that to work effectively on social determinants needs a whole new range of skills and knowledge. That for the most part, we have for physicians who have extremely limited background for work there. And then how do you work with the community? How do you most effectively advocate? how do you most effectively collaborate? Now, thinking about the latter, of course, there's increased emphasis on collaborative teamwork across health professionals, specialties, from social work to physicians to nurse colleagues and so forth and so on. And so, but then to extend those collaborative skills and something you might call collaborative leadership skills to work with a broad range of people to really make a difference in this area is really an extension. And so that it's a responsibility of the training programs to make substantial new moves to prepare people. Otherwise, you have a bunch of each individual physician is, well, I have to do something. Okay, what do I do? And I don't have much knowledge about it anyway, if they think that way. So I guess part of my interest is in just motivating a lot more preparation for people. And of course, that's not going to just happen in training programs. It's a learning curve that continues. When
Agree. So if it's okay, I would like to say to the group that Dr. Stone is a cardiologist. And so he understands from a physician point of view, right? It's in addition to what you do as a medical ethicist and everything else, right? So you're speaking from a physician experience as well. And I see that Dr. Tierney would like to make some comments. Dr. Tierney, please.
So hi, everyone. I'm Maureen Tierney. I'm actually the chair of the Department of Clinical Research and Public Health for both Omaha and Phoenix, Creighton School of Medicine. Thank you so much, Kate, for talking about this really crucial topic. And I think you and Dr. Stone have brought up, all the sort of crucial pieces of this, and that really addressing health and trying to achieve health is a collaborative process and needs to be that. And I'll put a plug, as you did, for understanding good local public health departments. And we here actually have a really good one, have usually done a very good job of a community assessment of needs and rank in public health. That there's really great models. So within communities, you'll have models of practices that really show that collaborative care. So University Campus, for example, here, which actually in Omaha, which actually works with its social workers, work with community link workers. St. Vincent de Paul in Phoenix. And so one of the things, in addition to the education about this that you've both emphasized, that I could see physicians going out in your practices when you finish, is to ensure whatever practice that you're in is based on a collaborative model that works with local public health, that works with community-based organizations and community leaders, and then the social work within your practice, making sure that those sort of circles of collaboration are sort of closed in being able to meet the social determinants of health with the patients in your practice.
Awesome. Thank you very much. I thank you for both of you, Dr. Stone and Dr. Tierney, for reinforcing the value of an interdisciplinary, interprofessional approach and working with the local health departments. Ashwini, I wanted to bring up the case study. Is that okay right now?
Yeah, we should. Yep.
Yep. Okay. Let me bring that up. So we're going to just briefly read through this, and then this is open for discussion from everyone. So here is you enter a room to see Mrs. Smith. You note she has gained considerable weight since her last visit. After greeting her and asking her how she's doing, she hints to having a lot of stress related to possibly losing her home. How do you address this situation? Yes, I can put the QR code up again. I'm happy to do that. How do you address this situation, considering the social determinants of health that we talked about and the resources that may be needed to help Mrs. Smith improve her health?
So there is no right answer.
Yeah, this is discussion. Like this is, let's talk about if this were your patient, no matter what your specialty is, okay? If this is your patient, knowing what you know now about the social determinants of health, and as Dr. Tierney and Dr. Stone said, collaboratively working with other people, help, let's work through this case study, please. And feel free to unmute. Dr. Tierney, your hand is still up. Did you want something to say something else, or is that up just because we didn't take it down yet?
Because we didn't take it down. Would love other people to hop in there.
Okay, cool. Thanks. Some comments on the case. Dr. Stone?
Well, I would say maybe this is really obvious, but I would say the first sort of humanistic and care related thing is to actually invite them to talk about the issue, as opposed to saying, oh, I'm so sorry, more or less, I can't help you with that problem. I mean, no, people wouldn't say that, but you might express that attitude. On the alternative, you say, okay, tell me, please, that's terrible. Tell me a little more about this. The other thing I was thinking of, because I was just talking to somebody in a different context this week about something, and I said, about how to improve a particular program. And I said, I might not know how to help it, but I might know people who know people who know people.
Right.
And so that's sort of the collaborative side in terms of promoting connections and help people navigate, and a whole host of things there.
Fantastic. And that's part of the point here, is to go into the practice of medicine with this understanding that I'm going to encounter someone along the way that's going to need some resource from somewhere. So if you put it in the context of the social determinants of health, where we live, work, and play, you should at least have resources available within your practice that you could turn over to a patient who articulates that they're stressed, and they're, and they may even say, oh, I know I've put on a lot of weight. Well, there's an opening for you to say, well, can you tell me a little bit more about that? Like, why do you think that's happening? So there is something in healthcare delivery called motivational interviewing, and it has been around for a very long time. And there is a book, Rolnick and Miller, I think Miller and Rolnick, I don't know which organization, but using motivational interviewing is a brief intervention and a way to get a patient to, as Dr. Stone was saying, to begin to talk about that. And I think someone in the chat said, I'd really want them to know, I want to know more about what's going on. And some folks, it may find it difficult to start that conversation, because are you sometimes looking at your clock going, I only have 15 minutes, I can only be with a patient for however long. Is that how you're practicing? And so you want to be able to get to the heart of these things. If you can get your hands on the book about motivational interviewing and healthcare delivery, it's an excellent kind of way to prep yourself for how to have these conversations in a way that elicits open responses. These are open-ended questions that get patients talking, and you can start listening for these open invitations, if you will, to talk about what's going on.
And again, it all stems down to how many of us take that time out, right? As
Right.
Dr. Nolt said, we have the next patient waiting. She's obese. I can give her some educational material to go over with. But no matter how much you educate her, the thing is, she does not have a roof over her head. No matter what you do, how you help her out, the fact that it's still bothering her, the fact that she won't be able to get back to a point where she's going to lose a home, literally takes over everything else than trying to figure out, should I go ahead and aim at losing 3 pounds by the next time I come meet my physician, which sometimes we do, right? This is the goal I want to set up too. The next time you come back to me in 3 months, I'd rather have you lose this weight and let's see what's going on, making sure your diabetes is much better and your hypertension is better controlled. But guess what? She may not even be able to make it to the 3 months appointment if we do not know what else is stressing her to get to the point she's gotten into.
That's exactly right. And thank you for bringing that, because remember, you as the physician don't have to take all of this on. You've got an office presumably in your practice that where they're part of this too. It's sort of a practice decision to have these resources available. And so you could make a note in the record, but then also if you walk the patient out or you have a nursing person or someone else, that medical assistant who walks the patient out, there could be a note, and the staff is trained to look for those notes on whatever checkout thing, and there could be a private area, of course, for HIPAA, that you end up having a conversation with the patient saying, I see that you might need some resources for housing. Can I give you some information or make a call with you? And so you're sitting in a private area, and the physician has now moved on to whoever the next patient is. So it's not that you have to do it all in the exam room. It's that the practice makes a decision to have an interest in looking further into what's happening to the patient, and has a whole mess of resources available to address whatever issues may come out of it. And it might end up being just another 5 minutes or so for a patient and for your team, but it could be a crucial 5 minutes in the health of the patient.
And
So,
it definitely makes a difference. It does make a difference to the community, to the people, to the groups of people that you end up catering to. And as Dr. Maureen was mentioning, simple examples, Vincent DePaul in Phoenix. What a community approach to taking care of patients. What a great community approach to make sure that we all cater to the different kinds of people, the insurance they have or not, their health problems, and trying to keep them healthy and safe enough than to keep coming back to the hospital. So it's a collective effort, cannot be done overnight, but it's definitely possible. And to me, whenever I talk about social determinants of health, no matter what they teach you in med school or how they make us grow as physicians, the one thing that stands out to me is we don't see polio today, because polio, if we did not do what we did to take care of polio, we probably would be dealing with such a huge different medical situation at this point. So that's a huge example that stands out in my mind to say it's a community approach, it's everybody together, and can definitely be done.
And the last thing I'll say is that this is not a passive approach to medicine. This is an active decision on your part, as well as who you practice with, to pursue this. And again, it does have an equalizing effect for people who do not have these resources when they get home. So this, again, when I started this presentation, it was to say, this is for your consideration and reflection as you begin to move through your careers in healthcare delivery. So I did put this back up. I did put the QR code back up. If there are any more comments, I'm done with my presentation. If anyone would like to add some comments, this is a great time to do that, or questions. Other than that, do we want to keep it up, Angie, the QR code? I can turn it back over to you, Ashwini, to round us up.
Thank you so much, Dr. Nolt, and thank you so much, Dr. Stone, who made time to be with us and